We've got another The Itch review for you today. This is where we're joined by Dr. Michael Blaiss to break down the latest allergy and immunology studies to help busy clinicians, patients, and caregivers stay up to date with cutting-edge research. Each episode comes with a one-page infographic for easy reference, so head to the show notes to follow along. Today, we're spotlighting the BATURA trial from the New England Journal of Medicine to see whether smart rescue inhalers can really cut severe asthma attacks in people with mild asthma. This podcast is made in partnership with the Allergy and Asthma Network. We want to thank AstraZeneca for sponsoring today's episode. While they support the show, all opinions are our own and sponsorship doesn't influence our content or editorial decisions. Any mentions of brands is for informational purposes only and not an endorsement. Now let's get into it. You're listening to The Itch, a podcast exploring all things allergy, asthma, and immunology. Welcome back to another episode of The Itch Review, where we talk about new journals. Today we are talking about a journal article from the New England Journal of Medicine published May 19th, 2025. And this is called As Needed Albuterol Budesonide in Mild Asthma. And the study is called BATURA. So this medication is a smart rescue inhaler, and it delivers quick relief and an inhaled steroid at the same time. So we're going to get into it, and I'm not the doctor, so I'm not going to explain it to you. And that's why we have two experts with us. But before we jump into what this actual study looked at, can you, Dr. G, give us a little explanation of asthma and the medication that's been taken for asthma so that we have a nice foundation?
Yeah, so to start off with mild asthma, which we'll define later, it affects between 50 and 70% of patients with a diagnosis of asthma, and it's often assumed to be low risk asthma, but actually severe or fatal exacerbations still occur in people with this form of mild asthma. And even if you're having infrequent asthma symptoms, up to 30% of exacerbations and also deaths are reported in patients treated for mild asthma or who have infrequent symptoms. So we really need to take this population more seriously. And if we remember, there are two types of asthma medications. One is a rescue medication and the other is a controller medication. So rescue medication has been an albuterol only medication. And what albuterol is essentially it's called a short acting beta agonist, which means that it is working on the muscles and the airways, and it's working on a specific beta receptor. And when activated, that causes the muscles to relax in the airways. So in asthma, what happens is that the muscles tighten up in our airways. And so this medication allows those muscles to relax again and allows the air to enter the airways, which is what we want. So normally what we're using is the short acting beta agonist. And again, that relaxes the smooth muscles in the airways. So we have recently started to rethink about what the rescue medications should have. And we're looking at it a little bit differently. And we've come to realize that treating inflammation, which is the second part of what happens in people with asthma, what we're learning now through research is that just opening up those muscles and relaxing those smooth muscles isn't enough during an exacerbation. And we also want to treat that underlying inflammation or swelling that occurs. And that's going to help more quickly relieve that exacerbation and prevent that person from going to the ER or emergency room. And that's always our goal.
So if I understand that correctly, what you said, Dr. G, is that basically there's two things that happen in asthma. We've got tighter muscles and we've got swelling or inflammation. And with rescue medication, you've only really been treating the tight muscles and not so much addressing the swelling. And now what you're looking at is addressing the swelling on top of relaxing the muscles.
Exactly. We're also wanting to look at the inflammation that can occur in people with asthma.
So the study that we're going to be talking about today is basically they're looking at adding a second medication to the rescue inhaler.
Right. So what we're doing now and what they're looking at here is adding a corticosteroid to the rescue inhaler. And as Dr. G was talking about, we now understand that one needs to treat not only that bronchospasm, air tubes constricting, but also treat that underlying inflammation if we're going to get that exacerbation under control. And as you said, prevent that patient from ending up in the emergency department. So we're seeing that shift now. We're seeing that shift in the guidelines that are being published around the world as far as the treatment of asthma. And we're now talking about what's called AIR, AIR, which stands for Anti-Inflammatory Rescue. In other words, using a bronchodilator along with a corticosteroid as a rescue drug. And in fact, if you look at the latest GINA guidelines, which are the global initiative in asthma, they make it very clear now that one should not just use a short-acting beta agonist alone, a bronchodilator alone, in the treatment of an asthma flare-up, but one should use one that also has an inhaled corticosteroid. Now, in most of the world, we have what's called SMART therapy, which is single maintenance and reliever therapy. And this is using an inhaled corticosteroid with a long-acting beta agonist like formoterol. This is used for not only all the time to prevent symptoms, so a controller medicine, but also could be used as a rescue medicine. But in the United States, we do not have an approved inhaled corticosteroid long-acting beta agonist that can be used as rescue. So in this particular study here, we're looking at the combination of albuterol, a short-acting beta agonist, and budesonide, an inhaled corticosteroid. That product is already approved in the United States for rescue for people with asthma 18 years of age and older. And that study was called Mandela. And it looked at patients that had more moderate to severe asthma. And in that particular study, they were able to show that using the combination of albuterol and budesonide showed significantly decreased exacerbations than what was seen with albuterol alone. In fact, when they looked at their primary endpoint, which was the time for the first severe exacerbation, it decreased by 28% with the combination drug albuterol budesonide versus albuterol alone. So this study that they named BATURA, in fact, they named all their studies after mountains. So this one is also. So in this study, BATURA, we're looking at intermittent and mild asthmatics to see if in this population we get fewer exacerbations related to their asthma. Now, this drug, the combined albuterol budesonide, is already approved in the United States for anybody with asthma, but we really haven't had data in patients that have intermittent and mild asthma, which really makes up the majority of asthma patients. So it's very important now to see this data to make sure that this is an appropriate treatment for all patients with asthma.
Great. That's really interesting that they want more information for mild asthmatics. What I would love is more information about what the difference is between a mild asthmatic and a moderate to severe asthmatic, just so we can wrap our heads around what you just said, Dr. Blaiss.
Yeah, so asthma is a spectrum. So on one end, you've got people who might only need their inhaler every now and then, and we call that a mild intermittent asthmatic. And so what that means is that they're very mild and that they really only need their medication intermittently when they're sick, during allergy season here and there, or if they're exercising, those kind of things. And then there's mild persistent asthma, which means that they are still on that milder spectrum, but they are requiring the need for their rescue medication more often. And we're worried that there may be some inflammation in their airway that we need to treat. And so these patients are called mild persistent asthmatics, and they're going to be put on a controller medication that has something to treat that underlying inflammation. On the other end, we've got the moderate to severe asthma patients, and these are people who are dealing with symptoms on a more regular basis than those mild persistent asthmatics. And on the severe end, they're having daily symptoms of coughing, wheezing, shortness of breath, waking up at night with their asthma. They're definitely on a controller medication to help control that inflammation that's occurring regularly in their airways. That inflammation can be controlled with a number of different medications, like inhalers and also the biologic medications that we've talked about a lot. Even though, again, moderate to severe asthma is concerning to us, I just want to point out again that our mild asthmatics are also ending up in the emergency rooms and in the hospital and are at risk of death. And so that's why we're really focusing on what we should be doing better for those patients too.
Great. Thank you very much, Dr. G. So basically what I'm hearing is that we want more information about whether this is going to work in mild asthmatics because, and I hear this all the time from my friends who have asthma, it's just asthma. Well, it's not just asthma because you could just end up in the emergency department if you don't have a good control on it, right? And I think that's the problem is we downplay asthma a lot. And what I'm hearing is that we want to look at better options for people with mild asthma because maybe adding in a new medication will make their management better. I don't know. Maybe I'm jumping into conclusions. So with that, I think we should just jump into the study. What was this study that we are talking about today?
So, if we look here at the study design, which I think is really interesting, is that this is a fully virtual study. We don't see that very often. I don't know if I've ever seen it before, where the patients, the subjects that were in this study, never went to visit the investigator. So they were never in an office setting. It was all done virtually. The recruitment for this study was all done pretty much virtually. In fact, a lot of it was done through social media. So this was fully virtual, decentralized, because again, wasn't any particular one center. This was part of what we call a phase 3B study. So again, one of the studies for approval, but this is kind of a post-approval study. And this was multi-center. So again, all around the country, double blind, which in this particular case means neither the participant, the subject in the study, or the investigator knew what product the subject was getting. And this was event-driven trial. So again, looking at events, basically we're looking at exacerbations here. And this involved people 12 years of age and older that again, their disease, in fact, was uncontrolled despite treatment for mild asthma. They could have either been on just a short-acting beta agonist with or without a low-dose inhaled corticosteroid or a leukotriene receptor antagonist. So again, these are all patients that are on medication that would fall under intermittent or mild asthma. The subjects that were in this study, they were randomized, again, 1-to-1, to either the fixed dose combination of albuterol 180 micrograms and budesonide 60 micrograms, where each dose was 90 micrograms and 80 micrograms respectively. So a typical dose, again, would be 2 puffs. Or they were given 180 micrograms albuterol, which would have been 2 puffs of 90 micrograms. And again, this was given as needed if the patients, again, were having symptoms for up to 52 weeks in the study. And they could use as much as they need with generally the maximum dose that is recommended is no more than 12 inhalations over a 24-hour period.
To summarize what I think I heard, first of all of the patients were virtual and they didn't have to go into the doctor for the study. And what those patients were doing is they were either being given the combination medication or just the rescue medication, which I think all of them had already been prescribed. And when they were having an exacerbation, they took that medication and that's what they're reporting.
Yep, absolutely correct.
So I'm going to talk about this later when we talk about the strengths and possible limitations of the study, but it is really cool that this was fully virtual. As somebody that practices mostly virtual, I think that we can accomplish a lot in the virtual world, and I think it is really helpful to patients and providers. So moving into who enrolled in the study, as Dr. Blaiss mentioned, it was anyone that was 12 years of age and older could enroll in the study who had uncontrolled asthma while taking the National Asthma Education Prevention Program Step 1 or Step 2 treatments. And that's defined as either as needed short-acting beta agonists, which we had talked about before, like the albuterol, or as needed short-acting beta agonist plus a maintenance dose of an inhaled glucocorticoid, which is the inhaled steroid medication, the anti-inflammatory, or a leukotriene receptor antagonist, which is another type of medication that we use in asthma that can help control the inflammation and the symptoms of asthma. And so those medications are the medications that are used for mild, intermittent, and mild persistent asthmatics. So that's the population that we're looking at here. And then not to get too detailed, but essentially they wanted to make sure that this was a true diagnosis of asthma. So their asthma diagnosis had to be provided by a prescribing healthcare provider. And that had to be given with documentation of either medical records or a letter from the treating physician so that that could be confirmed by the investigator that was pulling the patient into the study. So these were patients that had a diagnosis of asthma that was clearly stated somewhere in their records. And then the next thing that they wanted to make sure was that their asthma impairment and risk questionnaire, which is called the AirQ, and that's a score that we can get just by asking the patient several questions. And that had to be scored at 2 or higher. So the score goes from 0 to 10, with 0 and 1 indicating well-controlled asthma. If the patient hits a score of 2 to 4, they're not well-controlled. And if they're at a score of 5 to 10 on the AirQ, then they're really poorly controlled. And we'll definitely link the AirQ tool to this episode also so that people can see what those questions are and also see where they stand for their asthma to see if it's well-controlled or poorly controlled. But essentially, anyone that was enrolled in the study had to have an AirQ score of 2 or higher. So they had to be patients that were not well controlled or poorly controlled. And people that were excluded from the study were those that had uncontrolled lung disease that required more than just the step 2 therapy. They had more of that moderate to severe asthma, so they required more medications. And if they had greater than or equal to 3 exacerbations in the last year, then they were also excluded from the study. So with all of that, 5,221 patients came into the system that were screened. And then out of those patients, 2,516 people that were randomized, and they were each divided. Half of them received the combination medication and half of them received just the albuterol. So the combination was the albuterol plus the anti-inflammatory. And then they had 71% overall completion. They had some drop off in the patients that didn't follow through with the whole study. And that's to be expected in any study. And so ultimately, they had 903 patients that were on combination treatment and 894 people that were on just the albuterol alone therapy at the end. And the mean age were actually more adults. So at the end, the mean age was around 42 years of life, plus or minus 14 and a half years. So 97.2% of the patients in the study were older than 18 years of age. 68% were female, 18% self-identified as Black, and 12% self-identified as Hispanic, which when we're looking at studies, we really want to have diverse patients in our studies so that we can understand if all patients of different races will respond to the treatment that we're offering them. So this is very good as far as studies go to have a nice diverse population. And I personally think that that's because it was done in the virtual arena. And so it allows for patients to have better access to care if they're working 2 to 3 jobs, for example. And then their AirQ on average was 4.8. And so that's not well controlled. Remember, it went from 0 to 10, and 2 and greater was not well controlled. So that's a lot of information, but you can see it all in the infographic. And also, this is just the nitty gritty of who was enrolled, but essentially it was a relatively diverse population and mostly adult patients. And they were divided into 2 groups that received albuterol only or albuterol plus the budesonide.
So Dr. G mentioned 4.8 on the AirQ, and I'm just a little bit confused because I thought that we were talking about mild asthmatic patients. And if it's 4.8, to me, that sounds very high.
The reason they wanted patients that were not well controlled, because in the study, they're looking for exacerbations. And therefore, they wanted a group that was more likely to have exacerbations so they could see the differences between the two products.
And then just remember that they were on step 1 or step 2 treatment. So they were defined as mild asthmatics, but then they were uncontrolled. And as Dr. Blaiss mentioned, they wanted those uncontrolled mild asthmatics so that they could see how they did during exacerbations.
So now we know who was in the study. What were they looking for?
So, what they had here is the primary endpoint. So, the major thing that they were looking at was the time to the first severe exacerbation. So, how do we define a severe exacerbation in asthma? Well, there are several parts to it. One, either the patient has an exacerbation requiring 3 or more days of systemic corticosteroids, or they end up in the emergency room and require corticosteroids, or they get hospitalized related to their asthma, or unfortunately, they died related to their asthma. So, all of those would be under the category of severe exacerbation. And this was looked at in what was called the treatment efficacy population. So, this was the group that, in fact, completed the study. They also looked at what we call key secondary measures. So, one is they looked at the annualized rate of severe exacerbations. They looked at the annualized total exposure of corticosteroids. So, in other words, if you're having less exacerbations, you should need less corticosteroids over a year period of time. They looked at emergency department visits and hospitalizations. Very importantly, they looked at how much rescue medication was used in each group. They looked to see if there were any changes in the AirQ, again, looking at asthma control in the two groups. And they looked at all these also in the intent to treat population. So I mentioned before we had the treatment efficacy population, but also it's important to look at what's called the intent to treat population. So what do we mean by that? By intent to treat population, we're talking about all the participants that were randomly assigned to a treatment group, regardless of whether they, in fact, actually received the assigned treatment or completed the study. So it's everybody that, in fact, was randomized in the trial, even if they dropped out. And we saw that there was almost 30% dropout rate in this study, or they violated the protocol, or they didn't receive the intended treatment. Now, the question is, why is that important? Why should we know that in this study? One, it preserves the benefits of randomization. So again, you have all the patients that were placed in the study. Very importantly, it minimizes bias in the study, because if you just have the patients that completely finished the study, you're not including the patients that were non-adherent or protocol violations, and that may skew the results of the study. So it gives us really a more realistic estimate of true treatment effectiveness. We can then know that the results are more generalizable to the whole population. So it's very important in these studies to also look at the intent to treat population, everybody that took part in the study.
So if I understand that correctly, they were looking at all of the people in the study, and then you can break up all of the people in the study as the people who finished everything and followed the rules, essentially, and then those who didn't finish or did something that they weren't supposed to or forgot to do something. So then you have the end result of everyone who finished, but then they also looked at everyone together, and that gave them a better overview of what the study was saying.
So you look at it both. And if there are big differences in the results, then there may be some bias there. And so that's what you're really trying to look at here. So you want to make sure that when you do have a dropout rate, that again, you're not biasing the results of the study, because you're only looking at people that completely finished the study. And those patients may be somewhat different than the ones that, violated the protocol or didn't finish the treatment. So it gives us a better belief by looking at both populations and seeing how close they are together in the results of how accurate the study is.
Yeah, the intent to treat population is interesting, and it's something that you may see in other studies. So we thought we would define it. So now I'm going to be talking about the results of the endpoints that Dr. Blaiss had just discussed. So what the investigators had decided even before the study began was that they would do something called an interim analysis, which means that they look at the data in between just to make sure that they don't need to stop the study because there's a huge difference. And actually what they did find was that they did need to stop the study because of this interim analysis and looking at the data in the middle of the study to say, you know what, there is a big difference. And what they found is that the combination treatment of the albuterol plus the budesonide showed 5.1% severe exacerbations versus 9.1% exacerbations in the albuterol only group. So that's a significant difference. And at that point, they decided to actually end the study because the difference was so big between the patients that were receiving the combination treatment versus the albuterol only. And you saw that also in the intent to treat patients where they saw a 5.3% exacerbation rate in the combination treated patients versus 9.4% in the albuterol alone treated patients. And so what you're seeing here is that among patients 18 years of age or older, treatment with albuterol and budesonide resulted in a lower risk of severe exacerbation than treatment with albuterol alone in both the on-treatment efficacy population and the intent to treat population. So the risk of severe exacerbation was 47% lower with the albuterol and budesonide combination than with the albuterol alone, which led to the trial again being stopped early because of this planned interim analysis that showed that there was a huge difference. The people that were responsible for creating the study protocol had determined that when they hit 172 severe exacerbations, that would be that critical point where they wanted to look at the data and see what the data was showing. And if there was a significant difference between the people that were on albuterol alone versus the combination treatment, that they would stop the study. And that is in fact what happened. They did see that big difference that was statistically different. And so for safety of the patients, they did stop the trial in the middle because of that big difference.
And that's the key here. It's for the safety of the patients. Since there was such a big difference, it was felt that, again, the study should be stopped.
Is it common in studies to have this interim analysis because of the patient safety?
It depends upon the particular study and the risk of safety problems in the patient. We don't see it as much in allergy and asthma studies as you may see in oncology studies and others, but we definitely do see this being done in some of our studies. And so this one I think was very appropriate to do because, again, if you can see a major difference in severe exacerbations, again, and a lot of these ended up emergency department or hospitalized, that it makes sense that if there is a big difference between the two groups, that in fact the study should be stopped. And I guess the other thing you point out that it's enough data, and you saw the statistics, it's enough data to say that there truly was a significant difference.
They had enough information from the 172 exacerbations that they felt they could stop it and have a clear answer and not need to continue to see more just to make sure that this isn't a strange trend.
If there had not been a big difference between the two groups, then the study would have continued till the end. But there was such a major difference with a very high statistical significance. In other words, it did not affect to stop the study.
I mean, that's a really cool thing for the researchers to see, right? That this is working.
Absolutely.
That's every researcher's dream, I bet, to see, oh, dang, this is working. We can stop early. So what about, we mentioned the primary endpoint, but what about the other endpoints? Were they able to answer all of those questions even though they stopped the study early?
Yes. Again, there's plenty of data here in this study, even though it was stopped early. And if we look at some of the secondary endpoints, so if we look at the annualized rate of severe exacerbations in the group 18 years of age and older, it was 0.15 versus 0.33. So again, much lower number in the combo group. Annualized rate of severe exacerbations dropped by greater than half. When you look at prednisone burden, so the annualized use of oral corticosteroids, there was a dramatic decrease. In the group that was on the combo, albuterol budesonide, their annualized use oral corticosteroids, prednisone, was 23 milligrams. For the group that was on albuterol alone, it was 62 milligrams per patient year. So we're talking about a 63% difference as far as need for prednisone. And the question here was, well, why did the combo group here do so much better? Was it because they were using more of their medication than the group that was using albuterol alone? But in fact, the study showed that was not true. For rescue use, in this study, there was 1.5 puffs of the combo per day on average versus 1.8 puffs per day of the albuterol alone as needed. So again, virtually no difference. And they also looked at the mean percentage of days of more than 12 inhalations a day. Again, the recommendation is not to go over 12, but more than 12 would mean the patient's having a major flare up. And in fact, it was low in both groups. In the combination group, it was 0.59 days, and for the albuterol alone group, it was 1.0 days. Now, was there any major difference in the AirQ? Well, there was improvement in both groups, but there was minimal difference between the two groups. So I think what we can say here, as far as the secondary outcomes, is that the combination product, albuterol budesonide, was definitely superior to what we saw with albuterol alone.
Wow, okay, so it sounds like the group that took the combination rescue inhaler really did have less severe exacerbations. They didn't have to use as much steroids if they needed steroids. And it sounds like they weren't using their inhaler more than the other group. So these outcomes weren't because they were taking extra puffs.
Exactly.
And now, Dr. Blaiss, I'd love to know about the safety of the study. Can you tell us more about that?
Yep, and obviously that's very important for all of us. If you look at the safety data that was generated in this study, there were a total of 6 patients that were on the albuterol budesonide group and 20 on albuterol alone that discontinued the trial because of adverse events. And when you look at the overall incidence of adverse events between the two groups, they were really almost identical. It was 42.2% in the albuterol budesonide group versus 43.5% in the albuterol group alone. Now, what were these adverse events? Number one, we see this in most studies, was upper respiratory tract infection. Remember, in studies, anything that happens to the patient during the study is an adverse event. If you were driving and you were in an accident and you broke your leg, that would be listed as an adverse event in the study. So that's why you usually see upper respiratory tract infection so high, because people get colds. Also, this study was done during the time of COVID. So the second most common adverse event, in fact, was COVID infection. And number 3 was nasal pharyngitis. They also looked at what was considered to be serious adverse events, and it was about 3.1% in both arms. Again, nothing serious there. And then when they looked at local inhaled corticosteroid effects, because we do know that inhaled corticosteroids like budesonide can in some patients lead to some voice changes, can lead to thrush, or what we call candidiasis in the throat, and it was very low. It was 1.6 in the combination group, and albuterol alone, it was 0.6, and this was considered to be clinically minor. Now, there were 2 deaths in the study, one in the combo group, one in the albuterol group alone. Neither was reported as being related to the drug.
So it sounds like the adverse events weren't necessarily related to the medication. And then the one thing that you did talk about that was related to the medication was specifically because you know that a steroid inhaler can lead to certain things. And I know when I was on a steroid inhaler, I always had to make sure I rinse my mouth or else thrush would be a problem, right? So that's kind of one of these things of maybe you're not rinsing your mouth often enough. So now we understand the safety of the study. What about the strengths of the study?
Yeah, so I had alluded because I am a very virtual physician, and I think that virtual world is something that we can't minimize when it comes to treating patients and how important it is and how helpful it is. Having this trial be fully virtual and seeing how it provided for potentially more diverse patient population was really interesting to me personally, as somebody that feels very strongly that we should be doing more studies in the virtual world. And I think that some of the benefits of doing virtual studies from my experience in this area of medicine is that you really do reduce logistical barriers for patients. So I've seen patients driving to work, which, I usually have them stop so that they don't get into an accident and can concentrate on the visit, but they're also in their cars on their lunch breaks or in a side room where they can take a consult quickly between their shift. And also I see late night consults sometimes. And so in this world of people sometimes doing 1 to 2 jobs, as I had mentioned earlier, it's really nice to be able to provide that convenience and comfort for patients. And again, allow for people that may not have time to come into an office to be a part of these studies that often take a lot of time to be a participant in. And so I think that decentralizing the trials and allowing for people to have more access to these trials is super important. And also in rural areas and areas where you may not have some of these bigger study centers and trial sites, that also makes it more complicating. So it allows for patients that are in rural areas to also participate. So there's just a lot of different barriers that I think we take away that I think is very exciting.
So what about limitations in the study? So we talked about how it was great that it was virtual and it gave patients an opportunity, but was there anything that the study had limits?
So all studies have limitations, and this one, in fact, was 97% adult. And we really now need data in that 12 to 17 age group, the adolescent population. Also, we need pediatric data because we know more children, when we look at percentages that have asthma, than what we see in the adult population. So we really need that data so that hopefully this product can be approved for a younger age. One of the negatives of a virtual study, at least in asthma, is we don't have lung function measures. So all the patients here had to have a history of asthma documented by a physician, but we have no true documentation as far as lung function. And we did have a fairly high dropout rate higher than what we would see in, we'd call a non-virtual study. So we had that 28% dropout rate. So that obviously is a limitation too related to this particular study. But the limitations here are minimal.
Thank you, Dr. G, and thank you, Dr. Blaiss, for walking us through this paper. I would love to end this episode with what you guys take away from this. So what can you tell us after reviewing this journal article? Let's start with you, Dr. Blaiss.
I think the key take-home message here, at least for me, is that it's clear for all types of asthma, from intermittent all the way to severe, that for rescue treatment, the gold standard now for our patient is in fact using a inhaled corticosteroid short-acting beta agonist combo, as we saw in this particular study, albuterol budesonide, and that we should now be taking our patients off of albuterol alone as far as rescue treatment. It's clear from this study, it's clear from other studies that have been done with this product that it's definitely superior as far as decreasing severe exacerbations in all populations of asthma.
Yeah, I agree. And I think that it's super helpful as a clinician to look at this data and to see that that's true, because we've been using this rescue medication, albuterol, for forever. And that's the one thing that really hasn't changed. We've been doing a lot of different things for the controller medication, but for rescue medication, really albuterol has been our go-to. So seeing all of this data come out, I think just reinforces for clinicians that are set in their ways that we do need to think about rescue medication in a different way. I think it's very helpful to have this data. In addition, as I mentioned, I'm really excited that they did it in this virtual world so we can see what that looks like. And the last thing that I was really excited about was the reduced need for oral steroids, because that also is our number one goal. And we've had episodes on oral corticosteroid stewardship, but this just really solidifies that there are ways that we can help patients by using this combination treatment. So all of these things were, I think, just super positive for me. And I'm excited for this kind of shift in our thinking. And I'm excited to see what it ultimately does to our exacerbation rate in the future, and hopefully to the rate of asthma deaths, because we still have 11 deaths from asthma a day in this country. And so we really want to see that number go down.
Well, thank you very much again for walking us through and sharing your final thoughts. If you weren't watching this on video, we have an infographic that you can use as a cheat sheet if you didn't see any of the graphs that we talked about, which we're playing on the video, so you missed out. But you can check out that infographic, check out the article in our show notes, and also, as Dr. G mentioned, we have the AirQ questionnaire. So thanks again for listening, and we'll catch you next time.
Thank you for listening to today's episode. Remember that all information you hear today is for informational purposes only and are not intended to serve as a substitute for the consultation, diagnosis, and/or medical treatment of a qualified physician or healthcare provider. And also, don't forget to subscribe to our podcast. And if you have a second, help spread the word by rating our podcast and sharing with your friends and family who might also be interested in learning more about allergies, asthma, and immunology. You can always stay up to date by checking out our Instagram, The Itch Podcast, where you can leave questions you are itching to know, or check out our website, which is www.itchpodcast.com, which contains more information about the subjects we covered in today's episode and every episode. Until next time, have a fabulous week.